Okay, so today I just wanted to also go over a little bit more about some of the new surgical techniques, in strabismus surgery. A lot of this is transposition and vertical strabismus surgery, but also some aspects of some horizontal surgeries too. I have no conflicts of interest. So as far as just sort of what are we going to be talking about on the today's talk, I'll be discussing superior rectus muscle, and how it works and how it's being used in some of the newer surgeries, and then specifically for Duane syndrome and abducens nerve palsy. Also, I'll just be discussing heavy eye, sagging eye, some surgical considerations for that, and then lastly, third nerve palsy and my experience with surgery related to that muscle. So, difficult for business considerations. It's like adults do assess not only their alignment, but also their sensory status. I think I've hit up that pretty well. And then do they have diplopia with prism correction is applied? Can they fuse? And then lastly, vertical strabismus. I'll be sort of, is there a condition restrictive or paralytic? And is there a mechanical component to it? So when doing this, I just want to first initially review the extraocular muscle functions. And we have all muscles have a primary function, either in the XYZ plane, and but the cyclotorsional and the vertical muscles also have secondary and tertiary functions. So these are functions that are a product of the orbital path and of each muscle. And muscle action can actually change when the actual orbital anatomy is abnormal and it changes. So Strabismus surgery on the superior rectus muscle. The obvious is for patients with vertical strabismus. In this example, you can see in the upper right, there's a hypertropia, but also superior rectus muscle classically also has been done to assess dissociative vertical deviations, as you can see in the depiction now, where the right eye floats up with occlusion. Again, dissociative vertical deviation is often a product of a disruption of the binocular vision development in early ages. So whenever it is seen, most commonly by infantile esotropia, it is something that is tied to an infantile strabismus. So I'll see the dissociative vertical deviation on patients with infantile esotropia, but also a lot of early onset exotropia patients. Also see it in those patients too, because of the disruption of the visual system at such a young age. Superior rectus surgery, I find, is technically one of the much more challenging surgeries to perform. It's just the orientation of it, and how you have to sit with regards to the patient and the orientation of where they're located. It makes it very difficult to access the muscle, the pasturing of the sutures, everything just is sort of upside down and backwards. And because of that, it's often something that is related to a fellowship training in strabismus who performs this. So when looking at the superior rectus muscle and our orbital anatomy, we see the obvious where it actually will uh, 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 elevate the eye. But in addition, we also see the eye actually in cyclotort from the superior rectus actions, in addition to a deduct on the glow. So one of the newer procedures is the use of the superior rectus to transpose it to the lateral rectus. It's a newer option to manage patients with limited abduction, for example, cranial nerve 6 paresis, and also Duane's type 1 syndrome. This was actually first described by Johnston at a 2006 ARVO meeting, where he describes using this technique. And then more recently popularized by Dr. Hunter and Linda Daggy out of Boston Children's, with multiple published reports on this. And whenever I look at this procedure, as an engineer, it's hard for me to understand how this works and why it works because of how the forces act on the globe. It sort of contradicts what I had seen and talked about at the last lecture about the forces and how they act on the actual globe and actually on the eye. But after being a little bit of a doubter, I've taken this on and actually use it a fair amount when appropriate for certain select patients, most often adult strabismus. I found that this procedure with augmentation, with posterior fixation, as seen in this photo, is one technique. I've also done it without actual fixation, um, uh, which is shown in this picture here. So the benefits of this is that it allows for a concurrent transposition of the inferior rectus is not needed. Sorry. And it allows for simultaneous recession of the medial rectus muscle. And so, as we talked about before, I do use an adjustable suture for the medial rectus muscle when often doing this procedure. And main reason for doing this is it produces less fear of anterior segment ischemia. So if we go and we look at just sort of talking about anterior segment ischemia briefly, the source of that is it's tied into the anterior ciliary arteries, and just going over some of the basics. They run along the muscle borders of the rectus muscles. The classic teaching on the anterior ciliary arteries is that there is two arteries for the medial rectus muscle, two for the superior, two for the inferior, and then one for our lateral rectus muscle. This is all based upon a classic article by Lieber in 1903 that sort of had the first description of the vascular system of the eye. And this was mostly based upon whole mount specimens injected with Indian ink on a gelatin dye in the blood vessels. But subsequent studies have actually mostly confirmed, but sometimes I found different findings. So this is where we kind of go into another study. This is from a study in 1962, where they did analysis of 38 orbits by Hara. And in this, interesting, these anatomical findings show that there's marked individual variation on the number and distribution of the anterior ciliary arteries, particularly anterior ciliary arteries on the lateral rectus muscle. And so you can see here that on this, it shows that the actual lateral rectus, that there was two branches in more often than there was not. Again, this is 38 orbits on a select population, but the superior rectus actually had higher chance of having a single vessel compared to the lateral, which is our classical place of teaching for one. And then interestingly, the inferior rectus actually had the highest incidence of a single branch. So what does this all tell us? That it really is that there's lots of variations in the anterior segment blood supply. And so because of this, when I think about anterior segment ischemia and the risks for this, I tend to focus less on which muscle it is that I'm working on, but more on the number of muscles that I'm working on because of this variation. And we know that anterior segment ischemia, once you get past two recti muscle is being worked on, assuming they're not doing a ciliary artery sparing technique, that there's the increased risk of anterior segment ischemia. So typically two muscles. That's why whenever these procedures are being discussed, we talk about one muscle being performed in classic teaching on a transposition procedure would be inferior rectus simultaneous transposition to the lateral rectus for abducens nervus palsy, but that takes away some options as far as working on a third muscle. But if, which is what's been shown to work, is if we work on just one of those vertical muscles, the superior rectus, and transpose it over, that we can simultaneously work on the medial and not worry about anterior segment ischemia as much. So again, looking at the sort of diagram of the superior temporal orbit, you can see that we have the muscle, and the muscle taken away, and it's transposed over to the insertion point, the superior edge of the lateral rectus insertion, and fixated there. Sometimes this procedure is augmented by a suture approximately 8 to 10 millimeters posterior to that insertion. So I want to sort of present this patient, which is a patient with Duane's type 1. to the left eye. And you can see that by the, so I think I've got my little laser pointer here. So we can see that by looking at this, her left eye, and then as she looks to her left and abducts, we get this um, uh, abduction deficit and doesn't occur. But then looking at the opposite side, we get this lid fissure narrowing. So again, it's the classic findings of the Duane's type 1 on the left eye. So she had this procedure, which involved actually just the isolated because and the decision of how I decide of doing augmenting with the medial rectus recession or just recessing. Actually, she had the medial recessed also. But then you can see in this picture that the recession of the medial rectus combined with this augmentation actually increases and improves, this is what's unique about this procedure, is that you actually will get increased abduction. Whereas classically, when working with Duane's type 1, we would do a recession of the medial rectus. And the goal of that is to try to get improvements in primary gaze with little expectation of getting much improvement in abduction. But in her situation, you can see that we definitely were able to get abduction improvements on that lateral rectus by doing the transposition procedure. So this procedure, transposition to the lateral rectus muscle, it works well for Duane's type 1. I also find that with abducens nerve palsy, it's a stronger alternative to a typical R&R. And the decisions that I make about which one to use is often tied to the size of the deviation and how much function the lateral rectus will have. In patients with good recovery of the lateral rectus, it sort of is a gradation effect where I will do a Botox injection if it's a very small angle. And then next up, I would do a small medial rectus recession, and then third R&R for abducens. And then this will be the augmentation with the superior rectus transposition for the more severe. I find the larger recessions and resections don't work well because they tend to fail over time. The medial rectus recession allowed to be simultaneously with anterior segment concerns. So moving on, I wanted to discuss a little bit about heavy eye and myopic stenosis because it ties into some surgical considerations. And really with these two conditions, really the issue is muscle displacement is the source of the issue. You can see in this MRI imaging, localization of where the lateral rectus is with respect to the superior rectus is the source of these strabismus conditions, where you can see a downward slanting. The lateral rectus is laying lower than it typically would. And, have to give credit to Joe Deemer for doing a lot of the groundbreaking imaging studies looking at this condition and trying to better define what is exactly going on. This is from his sort of landmark paper I believe it was in 2015, where we actually looked at imaging and looked at gross specimens of the actual connective tissues. You can see the imaging in the upper on the left side, and then of the right orbit, and then on the right side is gross anatomy images of the left orbit. And on the left side, the arrows are pointing both to the left and the right orbits. But if you can see, the arrows are pointing to this connection tissue from the lateral rectus towards the superior rectus. And we call this classically the connection coin, the LR-SR band. And it is felt that the stretching of this band is the source of these either heavy eye or myopic strabismus or sagging eye, which is also divergence insufficiency type esotropia. Some believe that they're synonymous. But this band is what's contributing to the new onset esotropia, and in some cases, the small angle vertical strabismus that presents in these cases. So if we look at sort of the heavy eye syndrome and sagging eye syndrome, so heavy eye is also what we've considered a little of a myopic strabismus, and the sagging eye also considered maybe a type of divergence insufficiency type esotropia that we'll see in adults. And this table is actually from Joe Deemer's paper in 2015. So the clinical presentation for these patients is sort of, as you can see here, is that with heavy eye, it's a progressive esotropia that progressively worsens. It affects both distance and near, whereas sagging eye syndrome tends to be more mostly just at distance viewing, where you have diplopia distance fixation, but not at near. The underlying etiology of heavy eye is felt to be the high myopia, whereas the sagging eye is age-related changes of the orbital connective tissue, but also maybe a little bit less so, maybe related tied into myopia too. The concept is that anything that causes a degradation of the orbital tissue, whether it be the high myopia from pressure pushing on the LR-SR band, or the sagging eye, which is just age-related changes, can cause this condition to develop. When on duction testing, heavy eye tends to have limited abduction and superduction. This is probably from the slow chronic changes that occur in concurrent contracture of the contralateral muscles, whereas sagging eye might show a little bit of superduction deficit, but abduction tends to be more full. Additionally, the deviations, the size of the eye misalignment do tend to fluctuate and be a little bit different between the two. Whereas you have heavy eye syndrome, which tends to be larger size deviations, whereas sagging eye syndrome is in this article tends to be on the smaller side. My personal experience is that this deviation size is probably not as defined. I think you're seeing more on the extreme cases on this paper. And in my experience, I found that heavy eye syndrome should always be considered in any patient that has a history of high myopia, regardless of the size of the deviation, because I feel they present the underlying pathological process of what's occurring are similar. And so early heavy eye syndromes may actually be considered maybe almost a sagging eye syndrome. So it really depends if you're a splitter, a grouper, or splitter on how you define these two conditions. There tends to be more anatomical displacement when you look at the larger size heavy eye syndromes, where you get more inferior displacement of the lateral rectus and medial displacement of the superior. And then if you think of why this is occurring, it has to do with the global anatomy and if the eye is down and in, then the posterior globe is up and out, and that's pushing on that band and causing stretching. Whereas the sagging eye syndrome, it's more just a stretching of that band from orbital tissue changes and without the globe prolapse that you might see in heavy eye. The size of the LR-SR angle tends to be larger in heavy eye, and obviously the axial links are larger with the heavy eye. And there's different surgical approaches, and I'm not sold. His papers discusses loop myopexy for heavy eye and augmented medial rectus recessions. We'll get into that a little bit later, but I sort of have mixed feelings. I think that you just determines, it depends. It depends on the patient and sort of what's going on. So sort of highlighting the big differences between these two syndromes in the paper, are sort of highlighted here in the red, and the size of the deviation and also the angle deviation. So whenever looking at this, a lot of the discussion of how do you define and sort of diagnose this, it's all based upon imaging. Imaging on the paper in 2015, he shows here heavy eye syndrome is the top half when looking at this right orbit in both these two images. The top is heavy eye, where you can see that as you see the progression of going from the posterior orbit more and more anterior, you find this pretty uniform, starting even at the more deeper levels, coming more anterior, that the angle is large between the LR and SR, which is the last image at the top group, bottom right. But the thing is when you're assessing the LR SR angle, the goal is for us to try to get as close to the orbital sort of equator, the halfway point, right? Where close to where maybe a little bit posterior where the muscles insert. So whenever I'm measuring this angle on imaging studies, you have to almost sort of, it's hard to define where the muscles are at unless you start scrolling posterior. So you then project where the muscles are located as you grow more and more anterior, and then do the measurement based on the center of the globe to those presumed points of the muscle insertion. The second bottom half, you can see the sagging eye syndrome, where it shows that you have more on the normal anatomical location of the superior lateral rectus at the deeper levels, and you might get more just sagging of the lateral with respect to the superior rectus, and the angle between those two muscles are smaller. So whenever looking at a patient with this, possible condition, heavy eye, sagging eye, you know, it's real important to sort of look at and get a very thorough history. Trying to get an understanding of when the onset of this, the timing of this, and then looking, refractive correction. Many of these patients that come as adults, they've already had cataract surgery. So I do a lot of questioning on what was their refraction prior to their cataract surgery. Could they question I'll ask is, if you had to get up and go to the restroom in the middle of the night, did you have to have your glasses? Or could you at least get to the restroom without, could you see well enough without having to put your glasses on? These are questions to try to elicit sort of an understanding what their refractive correction was in the past. Looking at the 9 directions of gaze and motility measurements. And in this example, if we look at this patient, there's a small esotropia, maybe a little vertical strabismus, but I'd sort of challenge you, look and what do you see? What's different about this patient? And if you look carefully, you can notice that, well, it's the superior sulcus, that left eye, the superior sulcus. It looks recessed. It looks maybe atrophic. And this is, again, a big factor that I look at when I look at patients with new onset esotropia in adults, especially older adults, and also looking for that superior sulcus defect, because that's a sign of orbital fat atrophy that often extends back into the orbit. And then by default, also the LR-SR band has become more lax, and a possible source of the strabismus that they're noticing. So in this situation, it definitely suggests like a sagging eye. I pay particular attention to the versions, inductions, and look also with a torsional component, because I find that often there is, for more of the heavy eye, and also on some of the more severe versions of sagging eye, which I think are, again, a similar pathological process, you'll find some levels of torsion, specifically excyclotorsion. And that also plays a role in what to do to try to manage and help them from a surgical standpoint. Sometimes the MRI, I mean, I have to admit, when this was first being done, I did a lot of I did a lot of imaging. I do CTs or MRI scans. I do what I would call a quasi-coronal protocol, and had to teach my radiology sort of colleagues on sort of like what I'm looking for, and separately identifying the right and left eye orbit with this quasi-coronal protocol. So try to get more of a direct on the axis of the optic nerve going posterior, as opposed to the typical coronal images, which are sort of crossed at an oblique angle on the globes themselves. That's how you can kind of get more assessment. But as time has passed, I find that you end up not needing imaging. I know there's cost to imaging. There's prioritizations that we have to make. And once you start seeing enough of these and doing these, then I would argue you don't need to image a lot of these patients. And assuming that everything in the full workup is negative, including my typical, I always get myasthenia and thyroid labs on many patients, just to make sure that we're not dealing with one of those potential etiologies. So again, looking at those again, I tend to not image a lot of these patients now, and just know that at the time of surgery, you can identify some of the issues just by the appearance of the muscle locations at the time of surgery. And then also with a thorough evaluation with questionings, you have a pretty good idea about what may be the source of their issue. So looking at sort of sagging eye esotropia, looking at this patient, that's sort of, the question is that what's going on, or is this instead, is it a cranial nerve 6 paresis? So, this is where time course of onset really, really is important. Any kind of acute onset strongly suggests a 6 nerve paresis, although I've had 6 nerve palsies that were more chronic insidious from compression from tumors. But it gives you, if it was more of a slower onset with maybe more full motility abduction, then it might suggest more of a sagging eye. Refractive correction also plays a part. And then looking at in-gaze nystagmus. So in-gaze nystagmus, as you look at these patients and you have them abduct, you're looking for any signs of nystagmus present on extreme attempts of gaze. If you see that, it would be maybe more of a sign that this is a 6 nerve paresis, because that's more classically tied to that. However, and then with sagging eye, you tend to not see that. And then the size of the abduction deficit. Pronounced deviation deficits suggest a sixth nerve, whereas mild abduction deficits have been seen in more of a sagging eye presentation. So then we get to sort of, I guess, sort of the bigger discussion with this is what do you do and what's the surgical management for these two conditions? And as if you couldn't tell, I feel like these two conditions, I would consider them almost on a spectrum of the same problem. And so as opposed to, so I've sort of grouped them in a sense, but I think the surgical management on these patients, it varies and it depends on sometimes a lot of the size of things. So the classical, like if we go back, a lot of these patients were usually just treated with bilateral medial rectus recessions, and it would work well. Less well for the heavy eye because of some of the deeper anatomical changes for the larger size misalignments. But for the smaller size misalignments, the adults that maybe have divergent specificity type esotropia, the medial rectus recessions tends to work relatively well. In my experience, for like a sagging or a DIET, I find that it works well for the smaller size deviations. But if you think about what is going on, why is this issue? There's a good argument for possible lateral rectus resections being something to be considered. And the reason is because when you tighten up the lateral rectus, the anatomy suggests that tension, that increased pull that you're inducing on that lateral may help elevate that lateral and address some aspects of sagging of the lateral. And that's why a lot of times when managing these patients intraoperatively, you will see the lateral rectus just where it connects in the anatomy. It's sagging. It's actually dipping down as it arcs around the arc of contact on the globe and goes more into the posterior orbit. So that's why the lateral rectus recessions tend to be things. I'm doing a lot more R&Rs for these kind of patients than I used to for the smaller angle, just because I think that lateral rectus resection is helpful to do that. Then moving on and sort of what you would do, there's a posterior fixation suture placement to the superior edge of the lateral rectus. I find this is helpful to reestablish normal anatomy. So whenever I've done R&Rs and I'm looking at the lateral rectus, I might do a limbal incision just to get a better exposure. And when I resect, I'll then augment the surgery by placing a suture at the superior edge of the lateral rectus and then tacking it down to the sclera directly to recreate a more normal anatomical pathway into the posterior orbit for that muscle. And I feel like that seems to also help improve success. And then there's been people briefly, I think there's some people that discuss how just working on that band at a deeper level. I don't think that works very well, but there are reports on sort of just surgery on just the band itself, and then leading up to the myopexy of the superior rectus to the lateral rectus. And in this procedure, there's different ways that people have done it. They've split the superior and lateral rectus muscle in half and then myopexy, which is classically sort of a Jensen procedure. There's then also a silicone band loop myopexy, which is loops around the muscles and then ties down at a deeper aspect in the orbits. And then there's this suture union myopexy, which is the Yokoyama procedure, which is actually when I do a myopexy of the superior lateral, that's my preferred technique that I tend to use. So when looking at the superior myopexy to the lateral rectus, this is the newer option that people are talking about. It tends to be used to manage the moderate to high myopia patients with heavy eye. And again, it was first described by Yamaguchi in 2010 and termed the Yokoyama procedure. Imaging is helpful in confirming, but as I mentioned previously, it's not always required. And the relationship is, if you again think about the globe, if the eye's down and in, then the posterior aspect of the globe is up and out. And then this procedure, by pulling those lateral rectus muscles together, it prevents that subluxation of the posterior globe into the orbit and then helps provide realignment of the eyes. So what causes this myopic strabismus? Again, this is that gap between the lateral rectus and the superior rectus. You can see in this picture, it's that angle when the eye dips down and out, and induces this esotropia and hypotropia. I think your last year's lecture, Dr. Kushner, in his book, actually has a great anatomical from the posterior. I've seen lots of drawings of the anterior view of this, but this posterior view is a great sort of representation on what exactly is happening when you do this and re-pulling the eye. And also explains why this affects and helps heavy eye, the highly myopic strabismus patients, and that it helps stabilize the globe and prevents that posterior subluxation of the globe. So I wanted to present next is one of my patients that had what I found was myopic strabismus. In this photo, you can see that she had her eye was down and in slightly. She's actually wearing gas permeable contacts in this photo, and is really bothered not by double vision, but actually by the appearance. And so ended up doing that procedure, the Yokoyama procedure, fixating that globe, the lateral rectus, and you can see that when you do this procedure specifically, you get this improvement in the alignment. And she was actually very happy with the cosmetic results from doing this procedure, as it provided that stability. And this was without medial rectus recession, just suturing those two muscles together, pull the eye more straight and anatomical. I think this isolated procedure works well when dealing with patients on the smaller angle deviations. But whenever you get to the larger angles, sometimes it often needs to be augmented by the medial rectus being recessed simultaneously. So in summary, we've got our superior rectus muscle. It can be converted from a tertiary adductor to a strong abductor when it's actually transposed. It's isolated transposition of this muscle can be effective for Duane syndrome and also cranial nerve 6 palsy, and in heavy or myopic strabismus surgery on the superior rectus muscle, a posterior fixation suture, in addition to the transposition, is helpful to augment and further restore the normal anatomy for the patients. So now I'd like to talk a little bit about third nerve palsy. And in my experience, third nerve palsy is just one of the most challenging strabismus conditions to manage when it comes to surgery. For those that deal with this, that have done this, the procedures tend to not hold. They don't provide, a good long-term solution. And again, the way, we're taught is, think of it as the muscles that are not working. And strabismus surgery, in particular transposition procedures, when you work on muscles that are not normally functioning, the lack of tonic innervation causes the few muscles, like for the third nerve palsy, that are working to slowly over time take over, and you have reoccurrence of this large exotropia that tends to happen in this case, is a bilateral case. The reoccurrence, as I mentioned, is high, and unfortunately, all these surgeries that are out there to consider to try to help this don't help with saccades, and because of this, the binocular window is extremely small. So this small binocular window, if you can get them to a straight ahead position, they tend to be, in general, very unhappy because they can only fuse in a very small window. And then because of this, very, very unhappy, and whenever they get the results. And this is where you have to spend a lot of time really discussing with them and really going over what your surgical goals are, and what to expect from the surgery. Because while you can make the alignment better, the double vision, sometimes it's worse because it's brought more in the straight ahead position. So when we get to sort of the surgical options on addressing this, the typical R&Rs tend to not be effective unless you've had a significant recovery of at least a lot of the third nerve, and specifically the lateral rectus. If I find that the lateral rectus has function, you can get away with a recess resect procedure to address this condition. However, most of the time, often it does not recover, or you don't get recovery, and this condition goes to more extreme measures, which is why I wanted to sort of go over a little bit about a newer procedure that has been discussed by Linda Doggy out of Boston, and it's this lateral rectus transposition um, uh, of the split lateral rectus to the medial rectus muscle. So this is quite technically I would call it one of the more challenging procedures because you have to really know and understand your orbital anatomy and how you go about addressing it. And as you can see in this picture, um, get the lateral rectus, which is split, and then you suture each half individually by, let's say, a vical suture, and then you're passing this muscle, the superior half across the superior aspect, the inferior half on the inferior half to the medial rectus, to then suture them down near the medial rectus insertion to help with a deduction of the globe. Again, this is looking at now more of the superior half. Sorry, going back here. This is another view looking from above and below of this muscle procedure again. And notice the pathway of the lateral rectus and for both the superior and the inferior half. So I'm going to go a little bit more on just a little bit on the technical side. If you look at this, if we're looking at the superior half view from the two images that were shown here, you can see that the sutures, and this is where a gas hook is extremely helpful, are used to actually pass the sutures on that lateral rectus superiorly. And the trick is, if you look at where this gas hook is passing, is you localize through the superior temporal quadrant, and you're going behind the superior oblique muscle. And as we remember with the normal anatomy, the superior oblique tends to pass under the superior rectus muscle, approximately 5 to 8 millimeters back from the nasal edge of the superior rectus muscle. You go behind that, behind the superior, under the superior rectus muscle, and that's where you're going to pass those sutures to then drag it so that those sutures are actually going behind the insertion under the superior oblique tendon over to the medial aspects. If you don't do this, then you're going to get caught up in the actual superior oblique tendon, and that tends to you don't get good results. Let's just do that. Some people advocate actually tenotomizing the superior oblique. I tend to not do that just because sometimes if you need additional procedures, having access to that superior oblique may be helpful in the future. Again, this you can see here the superior half view of where that lateral rectus passes. And it's real important whenever you're doing this procedure to really, really go really far posterior on that splitting on that lateral rectus muscle because you've got to really, really split farther back to get really a good stretch and a good ability to get the eye over. One other thing that people that have done this procedure will talk about is how hard it is to advance that muscle up to the insertion on the medial side. A lot of it I find tends to be tied to the length of time that the individual has had this condition and how much contracture there is of that lateral rectus. The lateral rectus muscle, the longer it has been, so this has not been addressed, the more contracture and the more difficult it is to fully advance this muscle all the way forward. Again, looking at the inferior half of this procedure, again, you're looking at the inferior half of the lateral rectus. Again, you're going through with the gas hook under the inferior rectus, then behind, I would almost argue posterior, under the inferior oblique around, and that's where you're going to capture it, because then when you drag it through this technique, you're going to end up pulling the muscle back under the inferior oblique. Again, it's whenever you're looking and you're looking at thinking of you've got to get under that that white triangle. For those that do inferior oblique surgery, it's that white triangle on the inferior oblique. When you're looking back, you want to hook through that around it. That's sort of how you're going to be getting behind it to go in through that triangle to then be able to get past the sutures through that pathway. And again, pulling that over more nasal. I have mentioned, as I mentioned, that the length of time that someone has had this third nerve palsy and that contracture makes, I think, a difference in these patients. I've had a few patients that have had this, the third nerve palsy for a long period of time. And because of that, I end up, will Botox the lateral rectus actually successively just to try to loosen up and see if I can get some reduced contracture of that lateral prior to doing this procedure. I do think that makes a difference of being able to get get this lateral rectus all the way over to the medial rectus insertion. So I don't unfortunately have pictures of this patient, but I wanted to go ahead and present this patient. This is a post-op picture of a patient that I had. Now, again, when we think about this procedure, um, uh, which I'll play in just a second, I discuss about how we have to think of the sensory status of the patient. And this procedure is a great option from a cosmesis appearance standpoint on getting the eye better aligned. However, for patients that have new onset strabismus and acquired third nerve palsy, it tends to really be difficult on the patients because while the eye is anatomically more aligned, their sensory, their perception of double vision is actually sometimes worse because assuming the vision is good in that eye to start with, and they end up having really difficult fusing because there's a very, very small binocular window. This was a patient that I had surgery on with a congenital third nerve palsy. Fortunately for her, she actually had only mild to moderate to amblyopia due to patching history and amblyopia management, but was not binocular in a sense. And a lot of this struggles with socially with friends, and as a teenager struggled with this. And she started off with an exotropia of probably 35 to 45 prism diopters in primary gaze that with adduction increased to over 60. With abduction, at best would maybe an extreme abduction of the right eye would be maybe 15 to 20 exotropia. So let's see. There we go. Okay. So the thing that you'll notice is on this video is that you can see that when you recess that lateral and transpose it, she really doesn't get a lot of movement abduction and very little adduction present. But you can look up and you can see that she really doesn't. And then she goes down and there's really not a lot of depression. And so again, I'll play that sort of one more time. Hopefully, let's see. Again, we'll look at this again and just notice how the eye, there's not a lot of movement. And then the way I think of this procedure is when I have patients with this that are considering this, I have to warn them. I say, after this procedure, you'll get improvement in the alignment, but there's not a whole lot of movement. And going into this and really giving them expectations of what to expect after the surgery plays a big role on what and making sure they understand that this procedure, it works well from an anatomical standpoint, but you are not going to get really much movement of the eye. The eye will be anatomically straightened, and once you get into the side gazes, it doesn't do a whole lot. So, which is why I think this is a great option for people from a cosmesis standpoint, but less so if there's a binocular vision complaint. And in this patient in particular, after this procedure, ended up undergoing ptosis, surgery to address her ptosis that coexisted with the third nerve palsy. So with that, it's sort of concluded my discussion on these sort of techniques and sort of my experience. We talked a little bit about this third nerve palsy and sort of a newer option that's been out the last 10 years, but also some heavy eye, sagging eye, and divergences of sheath type esotropia, which is a lot of my adult patients end up having that kind of clinical presentation. We'd like to open it up for sort of questions and additional discussion.
Thank you, Dr. Miller. I do have a question here from Dr. Buglis. What sutures do you use for the myopexy?
Excellent. So it's a great question. What I found is that it doesn't, if I'm doing the junction between the superior and the lateral rectus muscle, I've been using just a straightforward vicryl. And I find that there's been some advocates for doing like a Merceline or a permanent suture, but I found that on the rare occasion where unfortunately I've had to go back and do additional surgery on these patients, I find that what you'll find is very similar, and which is mostly just a scar band that's been created by doing this myopexy. And so it either has a Merceline tied into it or it's a vicryl. Now, I will say that there are some people that'll myopexy the muscles to the actual sclera at the time. If that's the case, I tend to do more of a Merceline type suture just to get a better fixation to the actual globe. Although I found that scleral passes are not needed in my experience if you're just doing the myopexy of the superior to the lateral rectus muscle. If you're doing a myopexy in a sense of just supporting that lateral rectus, I've found that isolated myopexy of the superior edge of the lateral rectus, it works well and it holds and scars down if you use a Vicryl. So really, my non-adsorbable suture tends to be used less and less, and I tend to go with more of an adsorbable. And I found that even months down the road, the effect of the actual procedure holds and tends to not reoccur.
Okay. Next, we have a question from Dr. Wright.
Hi, Dr. Miller. Thanks so much for your talk so far and for doing this today. It's been phenomenal. I have a question that stems from your picture of that sagging eye syndrome patient with the unilateral left deepening of the upper eyelid sulcus. Just quick glance, first pass appearance, one thought that comes to mind is, are they unilaterally using prostaglandins? And while I recognize that in the setting of prostaglandin-associated periorbitopathy, the majority of it seems to be from periorbital fat atrophy, but just wondering if there's any data or any evidence or in your clinical practice, if you've noticed there's any association between prostaglandin use and LRSR band laxity, and whether or not you see sagging eye syndrome in those patients at all.
It's a great question. This is where it depends on, the glaucoma and also the laterality of it. Honestly, this is where I am not aware of the association, although there is a good question to see. I guess it's a matter of how deep the prostaglandins and how, the use at the deeper level. I think for a unilateral case, that would be a good, if you had someone just on prostaglandins unilaterally, and then you can show that would be an interesting finding, but I'm not aware in my practice. I haven't been able to associate that, but that's definitely something I think I'll probably look at and going forward and keep that in mind. Some of these patients with glaucoma come in, and it gets looping back towards our discussion on the sensory status. And when we get into glaucoma patients and field defects, a lot of patients will end up having that sort of strabismus in the diplopia. And a lot of it's tied to a field loss and their loss of peripheral fusion, which is so critical. The peripheral field is what helps stabilize a lot of the eye alignments. And when you lose that peripheral window of peripheral ability to fuse and hold images in place, a lot of these glaucoma patients, even with realignment surgeries, their ability to maintain fusion are challenged. So you kind of segued into sort of a glaucoma discussion, which is another sort of important consideration as the field loss and success postoperatively.
Interesting. Thank you.
Dr. Miller, I have a question regarding lateral rectus presses. So how you compare nasal transposition of lateral rectus muscle to the globe fixation, like periosteal globe fixation?
It's a great question. I did, when I finished actually just out of my training, I did probably at least a half a dozen, maybe up to 10 periosteal flap procedures. So the first thing is the difference between the two is, one, I need my oculoplastic surgeon, and the other I don't. So at the time, the coordination of care was a little bit easier, and I had an oculoplastic surgeon, and we would do this, and it tends to work. And you tend to you get a good fixation, and you get a similar results where you don't get a whole lot of movement, but the eye is anatomically improved in its location. The only thing about that, though, is I've had a fair number of patients with that periosteal flap procedure with significant chemosis that never really fully goes away. And so it's one of the things I did have a fair amount, but it's similar and it works well. But just in clinical practice, the coordination of care is probably one of the reasons why I've shied away from that procedure compared to whenever, 10, 15 years ago when I was doing it a little bit more. But definitely the periosteal flap is definitely a reasonable option. And it's great if you have an oculoplastic surgeon that works well with you, which most of us do that do adult strabismus. But again, it's the coordination of care a little bit that creates a little bit of challenge at times.
Thank you.
Dr. Aragutla?
Actually, there's a question in the chat box. Let's do that because I've had opportunity to ask questions before, and then if there's time, I'll ask mine.
Sure. So Sean asks, would you still suggest doing the superior rectus transposition to the lateral rectus in Duane's patients who don't have strabismus in primary position?
So it's a very good question. So this is where you come in and you're listening to the patient and trying to understand what their main complaints are and what their main problems are. Typically, if you have primary gaze, no strabismus, then usually you would not want to do strabismus and you would hold off on this. But what I found is that some of the patients, again, we're going to sort of qualify this by it's Duane's type 1 patients. So once you have these Duane's type 1 patients, what I do find is over time, and this is where you talk to the adults with this, they progressively tend to have a little bit more and more issues in primary gaze position. So when I start having sort of an intermittent diplopia in primary gaze, and you find out that these patients, as you look at photos and you look again, this is where the photos are so helpful, and you look at them going back decades and how they hold their head and looking at the camera for photos, you'll start noticing that a lot of these Duane's type 1 patients started taking on a little bit more and more head turn where they didn't have issues in primary gaze, but then start having a little bit of gaze. So you might find that there's an intermittent or intermittent esotropia in primary gaze, but guides me as a lot is on head positioning. And a lot of these people present with lots of neck strain, neck aches, and the symptoms of that might be a sort of, might guide me more to intervene even on a patient with primary gaze position with minimal strabismus, is if the head positioning is becoming more and more an issue. So head positioning plays, I would say, almost a bigger role. But then again, it's again discussing in advance with this individual, what do you expect and what are their goals? And if you were to do it and you do this, I would do an isolated transposition to the lateral rectus without medial rectus recessions, and making sure they understand that this procedure, while you get some improvement in the abduction, they may have new strabismus in the opposite direction. So you're trading off, and I like to think of people and telling them that you're shifting your binocular window, hopefully to get more in straight ahead. So when you do the isolated superior to lateral rectus transposition, you might get 10 to 15 degrees of improvement. And I always warn people that that's what you're going to probably get, but sometimes that's all you need to really make a big difference in their neck and their head turn and positioning.
Okay, Dr. Aragutla.
Dr. Miller, you had a slide which compared heavy eye syndrome with sagging eye syndrome. I don't know if it's possible to go back to that.
Yes.
But what I'm interested in is the axial length was 32 plus minus 5 or 6 on both sides. Now, my understanding is the classic heavy eye syndrome of high myopia, they're intrinsically, their axial length is longer. They are high myopes intrinsically, they were congenitally, they were destined to become high myopes. Versus the sagging eye syndrome, classically the classic teaching was not that they are high myopes. My understanding is their axial length was normal, and it was the adnexal tissue degeneration that caused it to sag. So based on Joe Deemer's paper, is he trying to say that high myopes could be, so in addition to the adnexal tissue degeneration, there's also like an actual axial length elongation?
So I think that what you're sort of describing is more of like a staphyloma type process where you get the globe itself expands posteriorly in that segment. Is that sort of what you're asking?
That's right. So classic teaching is that's what you'll see in the heavy eye, but in the sagging eye, it's not necessarily the axial length, it's the adnexal tissue, which is why you have that sulcus deformity or, those classic signs.
So I think that, I think that like in what you mentioned, absolutely with the large angle, again, it's almost like like I've had patients, and the question is, which one is it? You have a patient, they're like a -12 history, or they are a -12, and you see this condition, but the size of the deviation doesn't fit the classic heavy eye syndrome. They may have a posterior sapphiloma part aspect, but the size of the deviation, the axial length is longer, it fits better heavy eye. So it really, I find that it sort of depends, and that the underlying, you're right, that there's sort of extremes in the classic large misalignment, large angle crossing, larger vertical deviation. It tends to be much more, you get maybe this posterior globe change, but it's almost like a spectrum. I still think it's sort of the underlying, sort of the what's happening to cause the globe to be misaligned, is more of a deeper orbit LRSR band changes in degeneration. So this bring up I brought up the actual the table that you were wanting to show, and the points you were wanting to make is the axial length, I believe, and then what else was it?
That was mainly how I was surprised that axial length is pretty similar in both.
In his paper, yes, in his paper, that I agree that the sagging eye syndrome, which is why, again, looking at this in a clinical standpoint, we see, I think, much milder versions of what I would call in this, which is more of a sagging eye syndrome, but you could argue 32 millimeters is definitely actually longer. Maybe I mistransposed those wrong, but you're right.
Because you had mentioned that this was also previously called divergence insufficiency. So
no, and this is where I don't want to say that the adult onset divergence insufficiencies are this particular problem, but I think a lot of them are. And my belief is that the typical DIET patients with that small angle esotropia that have this sort of progressive increase in prism demand, I believe that a lot of those patients is in essence basically a sagging eye kind of presentation. I find that you don't get the vertical deviation that a lot of people will talk about, that you get a small vertical, but I find that also you'll get a little bit of torsion on these patients, specifically like cyclotorsion. And so it's sort of it's a spectrum of one disease, in my opinion.
My last question is about the transposition of the lateral rectus to the medial. And I've seen Linda Daggy present that at APOS, but why take the fibers through under the superior rectus and have to keep in mind the superior oblique? Why not through the inferior rectus? Yes, there is the inferior oblique that comes in the way when you split the lateral rectus fibers, but it's not intertwined with the inferior rectus. Like the superior rectus and superior oblique have a very sort of fibrous complex there.
So you're saying, like, as far as why do you need to go behind the inferior oblique?
Why superior pathway? Why not inferior?
Oh, for both. Well, I think that, again, this is where I go back to more of my engineering mind, in that you have to think about how that muscle and what's going to exactly happen over time, and that it's not going to be just where the muscle inserts. So even though you could, if you pass both edges through inferiorly and avoid the superior aspect, you still have the optic nerve, and you still have the posterior orbit tissue. So by splitting, I think of it more as a way of stabilizing the inferior half with the superior half by the forces, and now they act on the globe more in a symmetrical fashion. My concern, which I've never done everything through the inferior pathway, I've never, but I worry that by going that you may get more downward force just from how the muscle pathways. Even though if you could get the superior edge of the lateral connected to the superior edge of the medial area, I worry that it could create more of a hypotropia in that eye. But I don't know. I have never tried that. Maybe have you?
No, I haven't. Just
Yeah.
I've never had the
Yeah. The way I think of it is this, is that I think that a lot of these surgeries we do with strabismus surgery, and those that have to go back and unfortunate enough to have to do reoperations, you'll realize that a lot of these muscles that have been transposed, they convert a lot more or less to muscle and more to fibrous, like fibrous tissue and the scarring. And so I think that muscle, again, I've never re-opt on a patient that I've done this procedure for. Actually, I take that back. I've had one, and it was because, like you're insinuating, on that superior pass of the superior half, it actually got the superior oblique got caught up, and it actually it's an unpleasant situation. But again, going back to it though, is that those muscles, when you transpose them over, I think that they become more of a scar band, and it's more of less muscle is there left, and it's more scarring. And so that scarring, if it's more equally distributed between the bottom and the superior half, you maybe get more stability.